Welcome, everybody. And thank you to those joining us live and to those listening in afterwards. I'd also like to warmly welcome our guest today, whom I'll introduce shortly. We're pleased to be delivering this event, Supporting Self-Care in Children's Health, which is episode number 15 of our program of 17 events on self-care, shaping the future of self-care through pharmacy. FIP's vision is a world where everyone benefits from access to safe, effective, quality and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences and education. To introduce myself, I'm Dr. Dineen-Griffin, a pharmacist from Australia. I am an executive committee member of the Community Pharmacy Section of FIP and vice chair of the special interest group of New Generation of Pharmaceutical Scientists of FIP. Nationally, I'm Vice President of the New South Wales branch of the Pharmaceutical Society of Australia, a university lecturer and a community pharmacist. I completed my PhD exploring the role of the pharmacist in self-care. It is an honour and a privilege to be moderating this event. As healthcare providers, pharmacists have an important role to play in supporting self-care. This program is composed of 8 episodes that refocus on accelerating universal health coverage for all by enabling self-care through community pharmacy. And additionally, 9 episodes will focus on self-care support for community pharmacy teams. Today, we'll be continuing the focus on accelerating self-care for universal health coverage. Public health challenges such as COVID-19 has really highlighted the importance of self-care and has encouraged people to take health into their own hands. Consumers have turned to community pharmacists during the COVID-19 pandemic for health information and advice on how to self-care. Today's consumers are seeking informed advice on healthcare topics, and pharmacists play a critical role as frontline health professionals. Of relevance to today's discussion is pharmacist teams are increasingly supporting children and their carers with self-care. When it comes to children's health, pharmacists can help alleviate some of the health concerns for parents. Pharmacists provide families information about non-prescription medicines and treatments for children like paracetamol, antihistamines, and vitamin supplements. Correct dosing is important for anyone taking a medicine, but is even more important when giving medicines to children. Pharmacists can help parents with dose calculations based on ideal body weight if a child is particularly large or small for their age. For anyone caring for a small child, it's important to weigh children regularly, know how to interpret medicine dosage information on labels about age and weight, know how to use measuring devices and have the proper measuring tools handy, and know when and where to seek advice from a healthcare professional. Pharmacists are certainly part of a team that can promote a better understanding of what should and shouldn't alarm parents when it comes to the health of their children. Please note that this event will be recorded, live streamed on YouTube, and will be available at www.fip.org. To all those listening, please feel free to send your questions through the Q&A box, and we'll be picking up those throughout today's session. And I would also like to take this opportunity to promote the benefits of membership with FIP, including the events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. If you are a pharmacist or pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. Next slide, thanks. This self-care webinar on children's health is sponsored by Reckitt, and I would like to thank them for their support in this online program. So moving on to today's program, the aim of this session is to identify how the community pharmacy team can support self-care for common health problems for children and their carers, the appropriate management of choices of medicines and products to support children's health, and a case study will be presented and the event will conclude with panel discussion. We are joined by a panel of fabulous speakers from Lebanon, Australia and the United Kingdom, and I wanted to sincerely thank each of them for taking their time to prepare their presentations. I will introduce each of them in a moment. Moving on to the learning objectives. So this webinar will cover, firstly, increase the awareness of children's health issues, how common they are, what impacts they have, and how they can be managed. Secondly, learn how to support carers and children with common health issues. Third, discuss appropriate management in the choice of medicines and products. And lastly, describing the role of the pharmacist and their team can play in advising and educating carers and children so they can self-care. I'm now pleased to be introducing our first speaker of this webinar, Heidi Dazuki. Thank you, Heidi. He's community pharmacist and clinical instructor at Lebanese International University. He's a member of the Lebanese Order of the Pharmacist and elected for its disciplinary council. And he's received a distinction award from the Ministry of Education for his role in improving the colloquium oral exam in Lebanon. Thank you, Heidi. Over to you.
Thank you, Sarah. Welcome, everybody. It gives me a great honor and pleasure to be with you today. I'll take around 20 minutes to discuss some important aspects about common childhood conditions that are applicable to the pharmacy, which means I'm going to present these conditions from a pharmacist or from a practical point of view. I'll talk about 4 topics. First of all, I'll start with self-care, key concepts. What about developing a pediatric drug regimen? Then I'm going to go through some common pediatric disease from a pharmacist perspective, and then conclusions and take-home messages. As we know that children are not just like little adults, and lack of data on important pharmacokinetics and pharmacodynamic differences has led to several disastrous situations in pediatric care. We know that the variations in absorption of medicines from the GI tract, intramuscular injection sites, and the skin are important in pediatric patients, especially in premature and other newborn infants. We know that the rate and extent of organ function development and the distribution, metabolism, and elimination of drugs differ not only between pediatric versus adult patients, but also among pediatric age groups. We know that the effectiveness and safety of drugs may vary among age groups and from one drug to another in pediatric versus adult patients. And some concomitant disease like liver disease and kidney disease may influence dosage requirements to achieve a targeted effect for a specific disease in children. Because of that, we need some special methods of drug administration are needed for infants and young children. And we know that we have many medicines needed for pediatric patients, especially in less developed countries, especially in my country. These are not available in appropriate dosage for. So we have many challenges ahead. So one of the challenges that pediatric patients present at a specific time could be that we know that these pediatric patients are constantly changing both physiologically and developmentally. Not only this, the treatment decisions that we need to consider the parents, the family, as well as the patient. Because of that, many information also on the use of medication in children is evolving. So what's required to achieve the optimal care, the potential of care? What's required is a holistic approach to caring for the physical, mental, social, and psychological needs of children is required to achieve this full potential. Let me move now to have a small view about pediatric drug regimens. The component of a regimen such as the dose, the route, the frequency, the treatment, and the duration. We know that we have two main arms, the pharmacokinetic arm and the pharmacodynamic arm. Let me talk a little bit about the pharmacodynamics. We know that the oral absorption of some products, especially in neonates, infants, and children, they can be unpredictable owing to the variation in gastric pH and emptying time and intestinal transit time. So special care should be taken to certain formulations such as sustained release products such as thiophyllin. Concerning the distribution, we know that Some drugs that are administered by the intravenous, intramuscular, subcutaneous, or even topical routes, they have variable and unpredictable distribution, especially in neonates. This could be due to poor effusion for intramuscular, intravenous, subcutaneous, and topical preparation. This could be due to decreased muscle mass for intramuscular and subcutaneous injections, or due to difference in percentage of total body weight. Another physiological factor that may affect the distribution is the plasma proteins in neonates. We know that some drugs that are highly bound to plasma proteins may be more unbound, so more active drug circulating, so more adverse effects with this medication, with this important medication, phenytoin. Concerning other parameters such as metabolisms, we know that although neonates are born with all metabolizing enzymes, but we notice that we have reduced ability to metabolize some drugs is present, especially in the postnatal period. Some enzymes, sorry, could be defective, so we need to take care with special products such as phenytoin, phenobarbital, and diazepam. As I said, these are highly bound and highly metabolized products. Not only this, concerning the elimination, we know that the kidney is responsible for most of the elimination of some drugs, but the glomerular filtration rate is not that ideal, especially at birth. It represents only 50%, what it will be for the adults. So the elimination is prolonged. Therefore, we need to take a special precaution with some drugs such as vancomycin, gentamicin, ampicillin. Luckily, the glomerular filtration rate could reach 90% when the neonate reach 6 months of age. Moving now to pharmacodynamic considerations. In pharmacodynamic consideration, the ultimate goal is to have a maximum effect with minimum toxicity. For example, let me give example here about certain antibiotics. We know that certain antibiotics concerning the pharmacodynamics of them, especially the aminoglycosides, they work well, which means the killing occurs when the peak of this aminoglycoside is up to 10 to 12 times the minimum inhibitory concentration. Therefore, this could be achieved by providing a large dose of a drug to achieve a high concentration and high effectiveness. On the other hand, in contrast, for beta-lactams such as penicillins, cephalosporins, these are time-dependent, not concentration-dependent for that of the aminoglycosides. Those that are time-dependent, the drug kill most effectively when the blood levels above MIC are achieved through intervals between doses. So this relative small doses administered more frequently every 6 or even 8 hours provide optimal pharmacodynamic response. Another example is for some drugs that we need to know what's the importance of knowledge of these parameters. So knowledge of these pharmacodynamic parameters of drugs helps clinicians in anticipating when the therapeutic response could occur. For example, for theophylline, the effects maximize at 1 hour, prednisone, corticosteroids, maximum effect after around 6 hours, and they go back to normal, to baseline at 24 to 36 hours. So what to do? What factors affect drug selections? We have some patient-specific factors and we have some drug-specific factors. The most important factor in patient could be the age. This is one of the important factors that we need to select. The physiological and psychological age also is one of the important factors, the route of administration, the regimens, monitoring parameters. So the ability of the patient also, or the parent or caregiver, to accurately administer drug therapy can also affect its efficacy and safety. And I think we are here today to provide some important examples about these and some take-home messages that can help the patient or the caregiver to properly administer the drug to ensure efficacy and safety. In this slide, I'll focus on some patient-specific factors. For example, psychological factors. We need to take special care with some drugs. For example, ceftriaxone, third-generation antibiotic that's widely used. I don't know, here in Lebanon, we use it a lot for certain infection. This drug can develop or can increase bilirubin It may induce kernicterus in some newborns, so it should be monitored. For newborn immaturity, for example, some oral antibiotics could be unreliably absorbed during first month of life. For some renal insufficiency, for example, drugs such as also phenytoin, ibuprofen can have an enhanced action due to decrease in protein binding. Malnutrition also can affect the absorption. Short bowel syndrome can affect the absorption of also of some drugs. Some psychological and cognitive abilities, decreasing the understanding of directions indicated can lead to non-compliance of the patients. Another important factor, the psychosocial, for example, a chaotic home, multiple caregivers. This can have a difficult in adjusting or giving a dosage regimen. Another factor we are seeing a lot nowadays, the low-income families may have problems in ensuring or in paying for expensive medication therapy, and this also lead to non-compliance and incomplete dosage form. Some compliance issues, the taste of the drug, the schedule, the volume, for example, drugs that are could be tapered, or drugs that are given in a many intervals 4 times per day may have some difficulties. The availability of the drugs also represent another important factor, especially for pediatric uses. So factors to keep in mind when selected this one. We mentioned already patient-specific factors. For drug-specific factors, we need to mention the therapeutic index, and drugs with a wide therapeutic index are usually selected for initial treatment if possible. For the dosing, we have many formulas for the dosing. The most common formula is about the weight, the milligram per kilogram. This is one of the widely available and used dosages, but this should be considered in long-term therapy as the child weight may change. A more accurate data for more important drugs or narrow therapeutic index medications, such as anti-cancer medications, we need to consider the body surface area. The least accurate one will be the age. This is maybe common for some OTC medication. For some wide therapeutic index drugs, we can manage by knowing the child age and giving the right dose, but this is the least accurate method. This represents the first part. In the second part, I will need to mention some important diseases that may affect the child. We have many. I cannot recall all of the disease, but I'll pinpoint and highlight some important diseases that we see in the pharmacy, or some diseases that we are asked or counseled for some patients. Just to mention, for the newborns, although we are not seeing this in the pharmacy, but we have some major diseases affecting the newborn, such as the neonatal jaundice, hypoglycemia, and respiratory distress syndrome, others trauma, and other congenital defects. Starting with the skin, because this is the widely seen in the pharmacy, we are getting many questions about certain skin diseases. So, for example, to know or to diagnose skin disease, we need to have a certain background about the causative agent. Is it bacterial, fungal, viral, it's insect, it's dermatitis or acne. Many pathogens or many diseases affect the child skin. I just need to mention that we have a certain guideline in describing certain skin conditions. Examination requires that the entire surface of the body be palpated and inspected. Onset of duration of symptoms should be recorded. So we need to have a certain right terminology, and this may differ from country to country, but we need to have the right terminology, such as for scabies, for example. I'll highlight some important facts about scabies. We have around 20 million worldwide, affects 10% of the children. It's caused by Sarcoptes scabies. Of course, worldwide, most usual in hot tropical countries. These are some symptoms of the scabies. The female might burrow itself and lay eggs which hatch into larvae within a few days, and this may cause pruritus, which get worse at night. We have many sites that affect the scabies. They are I need to go fast just to cover all the topic. Usually remains to 3 days. It needs around 2 weeks as an incubation period. and we need to control scabies by giving medication to the patient and the whole personnel that are there. A good choice will be permethrin 5% cream, and should be kept for 8 to 12 hours and reapplication after one week. Dermatitis, another important skin condition that we see in the pharmacy, atopic dermatitis. We can see many eczema. By the way, we can formulate many medications due to the unavailability. We can formulate or we can mix different creams or ointments. We have many types of atopic dermatitis. Just to mention that sometimes the clinical progression from one atopic disease to another is referred the atopic march. This also could be seen with follow-up of the patient. Just to highlight some examples that we have some different locations concerning the infantile, the children, and the adult suffering from dermatitis. For eye problems, we have many diseases such as redness, tearing, discharge, pain, photophobia. Concerning the eye, we should not hesitate to contact the pediatric ophthalmologist when we believe that these signs and symptoms may exaggerate or we may have require in-depth clinical experience. In the pharmacy, we give many OTC eye drops, many hydrating medications, sometimes certain antibiotic, but this concerning the eye, it should be treated under medical supervisions. For the ENT or nose ontology, we see many diseases such as otitis media, otitis externa, mastoiditis. Just a take-home message here that we notice in the pharmacy that not all patients or caregivers continue the right dose for a certain antibiotic. If the child gets well after 2 to 3 days, most patients, they can stop the antibiotic. And this is a dangerous act that results in certain relapse or certain exaggeration of symptoms. So just from a pharmacist point of view, we need to ensure that for the patient to have or to complete the whole dosage for the whole days, even though the patient gets better. Many other conditions affecting the pediatric may be acute stomatitis, pharyngitis, and some common colds. That's now it's the main season. The cold, the influenza, the corona nowadays. For sore throat, just to highlight some important aspect of the sore throat, it's a scratchy feeling, it's self-limiting. It's one of the most symptoms that occur here in the winter seasons. We have many reasons for sore throat. Could be viral, bacterial, could be allergens, could be exposure to tobacco. Symptoms of sore throat are normally present at pain, difficulty swallowing, sometimes hoarseness of voice could occur. These are the red flag symptoms that we need to investigate more or refer the patient to a physician. If hoarseness lasts for more than two weeks, if it's a chronic sore throat, if you have some pain or difficulty in swallowing, or if we have a certain fever, we have some questions that we need to ask the patient. And we have this algorithm we can assess in the pharmacy. Of course, if identified, we can give certain medications, assess the symptoms, and give some symptomatic relief. And we should notice the red flag symptoms, or we should diagnose step throat that should be referred to physicians. For respiratory systems, also nowadays it's trendy in winter. We see many bronchitis, bronchiolitis, although we would not do an in-depth investigation at the pharmacy, but we are asked for many consultation about this. For the GI tract symptoms, for diarrhea also, it's also common, especially in summer. Just need to highlight some important red flag symptoms about diarrhea. Children less than 6 months of age, children suffering from dehydrations, or there is a persistent high fever, this should be referred to a healthcare physician. For urinary tract, we have also many diseases affect the urinary tract. We need, as a pharmacist, it's very important to detect these in children who are less than 5 years old, because these urinary tract infections may propagate or exaggerate or prolong to other organs and affect other body. Just to conclude, as I started before, solving this barrier, the pharmacist has a great role in supporting in self-care. Why? Because pharmacists are trusted sources of healthcare information in the community who can have a positive impact in health outcomes by empowering individuals to better care for their newborn. There is an easy access to the pharmacy concerning his own pharmacy or in conversation with him. Pharmacists can empower patients for better health choices. They work daily in direct contact with consumers, so these are easily accessible and can frequently discuss, prescribe, or even counsel patients. Community pharmacists provide education and guidance in multiple areas of self-care. Also, not only the pharmacist could be there, but also we can involve some parents need to be edified and encouraged as they take their role. And pharmacist remains the most trusted and easily accessible resource in these healthcare conditions and in supporting self-care for patients. And thank you very much.
Thank you, Heidi. That was really informative. And I really liked your last concluding slide where it said pharmacists are accessible, they're trusted, and can empower patients for better health outcomes, particularly when it comes to managing children. So thank you very much, Heidi. I'll now pass to our second speaker, Dr. Jack Collins. Dr. Jack Collins is a postdoctoral research associate at the University of Sydney in Australia. He completed his PhD in 2020 in community pharmacy, facilitation of consumer self-care. He's a community pharmacist and was the 2018 recipient of the International Pharmaceutical Federation's Young Pharmacist Grant for professional innovation for his work on implicit bias in pharmacists. Thank you, Jack. Over to you.
Thanks very much, Sarah. Hello, everyone. Thanks for joining us, whatever time it is, wherever you are in the world. All right, so I'm going to have a bit of a chat about the appropriate choice and use of treatments for children when we're looking at self-care in children. So I thought I'd just start off with something that's, I suppose, a little bit of a pet peeve of mine is self-care is not really perhaps the best term when we're talking about pediatrics. You know, is it a bit of a misnomer? So traditional definitions of self-care and self-medication certainly omit children and other dependents. So it was very much about the individual. And as we move towards updated definitions, the World Health Organization has certainly revised their definition recently to start to reflect the idea that it's more than just the individual when we're talking about self-care. We have individuals, families, which is probably most relevant in pediatrics, as well as wider communities, and they can all engage in self-care. When we're thinking about self-care in children, it's not just the child that we have to worry about. There's lots of people to consider. You've got the child at the centre who might be presenting with their complaint, their illness that they need assistance with. And then you might have, one parent, two parents, grandparents, other caregivers. You have siblings as well who may also take on the role of caregiving. They may also be sick and experiencing the same symptoms as the other child. You have teachers. There's all these people to consider when you're thinking about self-care in children, and that can make it quite complicated. So I just want you to keep that in mind as we're sort of going through today's presentation. If we think about the steps and the flow in pediatric self-care, you've got the caregiver or the parent, usually, who would first need to identify the signs or symptoms in the child. Of course, if the child's older, they might be able to vocalize those symptoms, but it may also be the responsibility of the caregiver to look at that. That caregiver then needs to kind of assess what they're seeing and reach a diagnosis, for the want of a better term, and decide whether or not they then need to seek help to provide care to that child. They then need to choose the treatments, dose and administer those treatments, and then continue to monitor the child. So I suppose the question here and why we're here today is, what is the role of the pharmacist in this? Where can the pharmacist slide in each of those different steps in this self-care process? And the answer is, of course, everywhere. There's certainly room for the pharmacist to assist in each of these different steps. So hopefully today we'll touch a little bit on certainly choosing treatments and assisting with dosing and perhaps administering those treatments as well. As I sort of alluded to earlier, self-care in children can be a little bit more challenging than just self-care of an adult patient. As I mentioned, it can involve several people. And is it really possible for the child to articulate their symptoms? Of course, if you have an infant who can't communicate, that's one thing, but even sort of children that can talk may not be able to really find the words to describe exactly what they're experiencing. Other challenges might include things such as inappropriate requests for medicines by caregivers. So people coming in and asking for medicines that are perhaps not the best to use in children. Self-selection of medicines, particularly problematic where you have children's medicines available in unregulated spaces such as supermarkets, and even the handover of care between different caregivers. So in that diagram I showed earlier, if you're sending a kid to school and they need to take those medicines or be given those medicines, how do you pass on to the teacher, for example? If you've got two parents and they're taking it in turns, how can we make sure that there's some kind of continuity of care between those different caregivers? There's a huge number and variety of formulations of self-care products in children, and I'll show you an image a little bit down the track about a variety of that. And you can see how it could be quite overwhelming to caregivers when they're trying to dose children. Even the carer's ability to dose medicines as well. So it's not really straightforward to just, pull out a cup and measure it out. They have to know the correct dose. They have to be able to use the measuring device. Are there multiple medicines? Is that child using more than one product, or are the parents using more than one product for the condition that child's experiencing? Is that child also using regular prescription therapy, for example? And how do we manage all of those in an unwell child? And we also know from research that there are certainly misconceptions in attitudes and beliefs around the safety of the medicines that are used in children's self-care, the severity of minor ailments, and so on. So parents may have this perception that over-the-counter medicines, because you can just buy them without a prescription, they're quite safe and it doesn't really matter if the dose is a little bit off or if you give a little bit extra, for example. On the other hand, you might have parents who get really, really hyped up and concerned when their child is sick, which is understandable, but it means that they may be very quick to medicate their child unnecessarily. If we are going to initiate treatment in children in a self-care space, I think it's always important to consider that medicines use should be guided by the principles of quality use of medicines. So understandably, that looks a little bit different wherever you are in the world and what your regular practice setting is like. But usually, that would be ensuring that there's a need for medicines. So as I mentioned earlier, even common medicines, which we can get without a prescription, are not without their risks. So is it really necessary to medicate the child? Are we going to expose them to this medicine? The risk of a dosing error, the risk of an adverse reaction, for example. Make sure that there's actually a real need for that medicine in the first instance. Obviously, other important aspects of the quality use of medicines are making sure that we have the right medicine and the right dose, the right interval, the right route, for example, and appropriate monitoring as well. So we need to make sure that whatever medicine we choose is appropriate for that child. So we would like to consider what signs and symptoms they're presenting with, which would help us reach our differential diagnosis. What's the child's behavior like? Are they actually concerned by their symptoms? Are they still eating and drinking normally, for example? How much do they weigh and their age? So Hardy gave us a very good overview of the different pharmacokinetic parameters to consider. And this, of course, means that as pharmacists, we need to make sure that we're taking an adequate history. We need to question the caregivers, try and get as much information as we can so that we can best assist them. We spoke a lot about, in the first section of today's presentation, about some of the pharmacokinetic and pharmacodynamic things to consider. I think also there's other formulation considerations. So flavor, when I work in the pharmacy, that's always one of my first questions after reaching the important clinical steps. I often hear, no, my child won't have peach, they won't have strawberry, they won't have orange. So these things really do matter if you want to make the medicine giving process as easy as possible for everyone involved. What storage is required? Certain medicines that may need to be stored in the refrigerator, for example, that may not be convenient for some people. Are there any allergens present in those medicines or any potential sensitivities to any of the actives or excipients in those formulations? Cost could be a considerable thing that you may need to consider. And what are the past experiences of that parent and that child? If it's something they're familiar with, a product that they've dosed before with that child, it may be more comfortable for everyone involved to use that again if there was a successful trial in the past. So we need to make sure that caregivers are provided certainly with adequate directions, written information if you can where appropriate, and that they're advised of what monitoring might be necessary while they're dosing the child. So how do we look out for symptom improvement? When might we need to refer? Any key adverse effects that you may be concerned about, depending on the individual medicine supplied. And there may be instances, of course, where the therapy is not indicated, and that's sort of also our role as pharmacists, is to decline supply of a medicine part of quality use of medicines is making sure that they're being used when required. So if you are going to decline the supply of any medicinal products, I think it's great that you explain your rationale for that. That person's coming in expecting a product. If they're going to leave, it's good that they know why they're leaving without a product, and certainly giving them advice on how they can best proceed from there. So whether that's non-pharmacological intervention or if they need to be referred to a hospital or a general practitioner, that should certainly be articulated to them as well. We know that the use of over-the-counter products is very common in children. So this survey of approximately 350 parents found that over 95% of the respondents reported buying over-the-counter medicines for their children in the last 12 months. These are the most common medicines that they reported purchasing. This is based in Australia. I don't think there's probably anything here that's too surprising. Paracetamol and ibuprofen certainly topped out the top two positions. Choline salicylate, again, in children with teething, that's not surprising. Some things for some dermal conditions, antihistamines, cough, cold preparations, and saline spray, conditions that we expect to see in children and that are quite commonly presenting in children, especially in the pharmacy when they tend to be of a more minor nature, and the pharmacy is often the first port of call for parents. Interesting if we look at some of the research about misconceptions that parents might have about medicines. So one of the interesting things I found in this study I was reading, that caregivers certainly are influenced by packaging and branding. So if they were given an over-the-counter product to look at, they would tend to focus on the big words in the packaging that would say children, child for this condition. If there was an image of a teddy bear, for example, or a happy smiling child, that would really sway the way that they would perceive the safety of that medicine and how they would use it. And it was often seen that they would disregard things such as dosing directions, warnings, and those other probably more important aspects of product labels. And it's also shown that parents may socially medicate their children to give them perceived control over their child's behaviour. So in that particular study, in the interviews with parents, they reported things like they would give their children paracetamol because they believed it had a calming effect on their children, sedating antihistamines before long travel, for example, in a car. So we do know that there are certainly parents who may request and use medicines in children where it's not necessarily appropriate. And again, that's a fantastic opportunity for the pharmacist to step in and kind of clarify some of those misconceptions and steer caregivers in the right direction. This is the slide I was alluding to earlier. This is certainly what someone's medicine cupboard could look like at home. This is a range of different products. There's some ibuprofen syrups there, some paracetamol syrups, antihistamines, there's some gripe water, and a variety of different dosing devices. Some measuring cups, common kitchen spoons, unfortunately, we know are definitely used to dose children, as well as some syringes there. So you can see how this array of medicines, this is what it looks like as well when a person walks into a pharmacy and they're all on the shelf. It can be quite confusing to parents or other caregivers. There's a risk of duplication of therapy if they pick up two products that contain paracetamol, for example, but they're different brands. Some of these are sold in different strengths, so the dosing's not the same between formulations. It can be quite confusing for parents. There's certainly always room for the pharmacist to provide education. So as I just mentioned, there's different formulations and strengths of the same medicine. So you really need to make sure that if you're handing over a product to someone to help them care for their child, that you're giving directions specific to whatever you're handing over. And I think it's always great to clarify. I know you may have used, for example, a paracetamol syrup in the past. For this particular one, these are the directions for this child at this time. Dose according to the best practices and your local formularies. The dose is going to be different in different parts of the world, so make sure that you're following whatever's best practice for where you're located. For example, for weight, for age, this all depends on the drug and the formulation, of course. Perhaps the ideal body weight if you have a high proportion of childhood obesity and the drug's not fat soluble, such as the case of paracetamol. When we're looking at weight-based dosing, we'd like an accurate weight ideally. So if you can weigh the child, if they're standing there in the pharmacy with you and you've got scales, pop them on there and get an accurate weight. It's great. It's not really helpful to have a weight from 6 or 12 months ago. Obviously, children grow a lot. That's part of growing up. So it's good to have a really current weight in that case. And product information can be confusing to caregivers. So before we started today, we were having a bit of a chat about this as a panel. This is commonly what a product information will look like to a parent. They've got to choose between an age, an average weight for that age, and then dose according to that. It's very confusing. You know, what if my child's on the cusp of these two brackets? What if they're 7 years old, but they actually weigh 26 kilos? What do I do? I've got this range. Does that mean that if they're 25 kilos, I go for 8 meals? There's a lot of things for caregivers to interpret and consider there. And certainly that's where we can provide guidance and explain the clear dosing to parents. Ideally, we'll use a syringe to administer medicines to children, particularly younger children, and medicines where we'd like a more accurate dose. And certainly we need to provide some education on how to use these syringes as well. So different proprietary products may come with different styles of syringes. So you may need to re-educate parents based on the syringe that comes with that specific product. Some of them, for example, may be designed to screw into the bottle that you're supplying. So again, every time we're supplying, great chance for educational intervention. Provides more accurate measurement and aids dosing, so you can squirt it in the child's mouth, which can be helpful. Certainly not right at the back of the throat, because if you hit the back of the throat, that can initiate the child's gag reflex, which will make them more likely to spit it out or regurgitate it. Measuring the dose, administering that single dose is one thing. We also, of course, need to consider the dose interval. It's different for paracetamol and ibuprofen, which are the two top used medicines. So make sure that that's really clear as well. And what does that dose interval mean? What does it mean in terms of maximum daily dose as well? Because that can be quite confusing to caregivers. And education on not to repeat the dose if there's a partial dose given, or if it's regurgitated or spat out. We should be waiting in the full dose interval before we attempt to redose, because it's just not possible to know how much of that dose was ingested. So you may want to think of ways you can assist caregivers with ways to administer medicines. Can it be mixed with a small amount of food or a drink, for example? Give before eating, as the child may be more likely to swallow. Explain the purpose of the medicine to the child so they know why they're being given the medicine, and not to refer to medicine as candy or to threaten a child with medicine. That can create some really negative psychological behaviors around the use of medicines. Just touch on antipyretics and analgesics quickly. So as we've covered, they were the most common medicines used in pediatric self-care. They're used for things like fever, which Joe is going to have a bit of a chat to us about after this. Some cough, cold symptoms, for example, teething, or even just any sort of non-specific pain. Adults also use ibuprofen and paracetamol. Paracetamol can be used generally from 1 month of age, and ibuprofen from 3 months of age. And they're actually very well tolerated with limited adverse effects when they're dosed correctly at an appropriate therapeutic dose. So that's the key thing there, making sure that we're getting the right dose for the child. Combination of two agents is not routinely recommended. It's often unnecessary, and parents can mix up the doses between the two different formulations and the dose interval being different. Parents certainly may have a misconception about the role of these medicines. So explain why we're giving paracetamol, for example, and what purpose it is, what it's going to help with and what it's not. It's not going to calm children down or sedate them, for example, which is the misconceptions that's certainly reported in the literature. And it won't modulate children's moods either. Might make them feel a little bit better, which perhaps may change their mood, but it's not directly changing the mood. Just in this study, I thought I would mention quickly, one of my colleagues did this with 101 caregivers, gave them a little case. How would you dose your child if you were giving them this medicine? And they made errors at almost every step. So right from using a syringe to calculating the correct dose to the dose interval. And overall, it was only about 30% of caregivers, there we go, 1/3 that managed to correctly dose. So these were university educated caregivers as well, for the most part. So even people that we might perceive to be very health literate may not necessarily be able to appropriately dose. So just quickly on cough cold products, children experience more colds than adults each year. It's probably around 10. It's a few more than the average, or at least in pre-pandemic times. They often contain multiple ingredients, so they're not ideal to use, and there's limited evidence regarding their efficacy. So many jurisdictions, they've been banned for under 6 years of age, just based on that. There's a little marketing trick which has been happening recently, where it's now being marketed for allergic rhinitis in kids aged 2 to 5 years. So they're just changing the indication to try and get it across. Still probably not an ideal thing. You can use a regular, less sedating antihistamine in that case. So even in 6 to 12 years, best to approach with caution. And you can see that they even give you a free measuring cup in this formulation, which is probably not ideal to use for dosing either. So you can consider alternatives in children under 6 years and age 6 to 12. So saline sprays or drops, steam or a vaporizer, perhaps honey even may have a role. There's limited data for herbal alternatives such as Hedera helix. And educate on non-pharmacological interventions such as adequate fluid intake and rest, and again, managing expectations and educating. Just some medicines that you might want to avoid or use with caution. The cough cold products I just touched on. Sedating antihistamines, particularly in children under 2 years, it's quite dangerous. Aspirin, because of the risk of Reye syndrome. Viscous medicines in younger infants, so really young infants aren't able to swallow very well. So miconazole gel, for example, may not be ideal. Complementary alternative medicines often don't have very good safety and efficacy data in children. It's probably best to avoid. And if you are in a jurisdiction where you can give antibiotics without a doctor's prescription, certainly be considering whether those antibiotics are appropriate to give, and if it's best that you don't. Consider the need to refer to a medical practitioner if there's any red flag signs, such as a stiff neck, a high-grade fever, dysphagia, excessive drooling, signs of dehydration, and so on. Always try and hand over some written information and any practical advice where you can. And as I mentioned, even parents with higher levels of education and literacy may have trouble dosing medicines. So always step in, you're the pharmacist, you're the medicines expert. Use that to your advantage and try and help caregivers of children in the space of self-care.
Thank you, Jack, and great presentation. A few slides I'd like to touch on because I found them really informative. So firstly, you ask, where can the pharmacist fit in with respect to self-care? And your answer was everywhere, and I absolutely agree. One of the other slides mentioned that medicine should be guided by principles of quality use of medicines and to ensure that there is need for the medicine for their child. You provided some really practical tips, such as flavour and storage considerations. And lastly, you mentioned that 33% correctly dosed for fever. Wow, self-care and health literacy is very important. So thank you very much. That now leads us to our next speaker, which is Jo Crook. So Jo is a consultant pharmacist for pediatrics based in the United Kingdom. She's a hospital pharmacist, independent prescriber, and honorary lecturer at UCL School of Pharmacy. I'd now like to hand over to Jo to talk through her slides. Thanks, Jo.
Hi there, thank you very much. Yeah, I'm Jo Crook. I'm a consultant pharmacist, and today I'm going to need your help, please. So don't be shy. There are no wrong answers. This is a very safe space for learning. So please do take part, because I can't do this case study without you. So I'm basically going to take you through fever and a case study of a young mum who brings a baby in. And I'm going to be asking lots of questions. So please do take part and type in the chat for me so that we can have a great discussion together. And I'm also going to cover how to keep families well through winter. So probably quite a familiar situation for most of you who are community pharmacists. A parent brings in their miserable 3-month-old to the pharmacy. They've wrapped them up in blankets in a car seat, and they're really concerned because they report a temperature and they're not acting like their normal self. So what kind of questions would you start with to ask this mother? If you can just type some questions in the chat box, that would be really great. So we've got a miserable 3-month-old wrapped up really warm in a car seat, and mum's concerned that they have a fever. So what kind of questions will be asked? Yeah, perfect, Donna. So how long has the child been unwell? So has the fever been reported overnight? Have they had the fever for more than 5 days, which I'll come on to later? That's quite an important point. So how long has the illness been going on? And then normally linked to that question, is the child getting better or is the child getting worse? So if you have a child and the parents report that they're getting worse within their illness, and that would be a little bit more concerning than a child who's generally quite happy and is doing okay. What other questions might we ask the mum? Yeah, perfect, Elizabeth. Did you measure the temperature? So a lot of parents might have a thermometer at home. So did they measure the temperature and what was the reading? Any signs of any distress? Perfect. So we're also looking for any other signs of symptoms. Yeah, that's brilliant. Renly Lim, sorry if I've mispronounced that. So we're looking for any other symptoms, particularly have they got a rash? Have they got any difficulty in breathing, fast breathing, any funny noises, cough, sneezy nose, ear rubbing? So have they just got a simple fever on its own, or have they got anything else to go with it that might give you a clue as to what might be causing a fever? You might also want to ask with a 3-month-old baby whether they've been recently vaccinated. So in the UK, it's quite common for a 3-month-old baby to have their vaccinations at that age. So they might present with a fever post-vaccination, which would be a different scenario to a child who had not been vaccinated. Yes, perfect. Kartik, have you given any medication? What did you give? How much did you give? And what effect did it have? Has the fever been consistently high, or is there a period when it came down? So I guess that question is more in relation to did the antipyretic work? So if they have already given an antipyretic like paracetamol or ibuprofen, did it work? Or yes, you could ask whether they're constantly feverish or whether they've just had one fever and then it's dissipated on its own. So yeah, all really good questions to ask. So that kind of answers the next question. And what common causes of fever in children less than 5 years? In winter, it's normally viruses. Sometimes it can be rarely a bacterial infection. Very rarely it can be a sign of serious infection like meningitis or sepsis. But also quite a very common cause is from vaccination, especially in the under ones. Oh, sorry, I just moved my slides on. So mum doesn't have a thermometer at home. How else might you be able to check whether the child has a temperature? What else could you potentially look for? So if she didn't have a fever thermometer, sorry, what you could look for is a baby that's hot to touch. Now, this particular baby was wrapped up really warm in his car seat. So you'd want to undress the baby to its normal state. Quite often new mums might overwrap their babies too hot in the pram with loads of blankets, especially in winter, which then understandably increases their temperature. So if you unwrap them in just normal clothing and then take their temperature, that can often be the best way. So you can just feel them if they're hot to touch, if they've got red rosy cheeks, if they're a little bit distressed, then quite often that is a sign that they have a temperature. But ideally most parents should have, if possible, a thermometer at home. So does anyone know what kind of thermometers you would recommend to measure a temperature in a child? So if you had to measure a temperature in the community, what kind of thermometers would you recommend? It's interesting to see what's available across the world, actually. Definitely a digital thermometer. So if you've got a baby under 4 weeks, in the UK, we recommend a digital under the arm axilla digital thermometer. If they're over 4 weeks, then you can also use an in the ear infrared thermometer. You can use the digital under the arm, but what we don't recommend is the forehead measurements. So they're not reliable enough for healthcare professionals. So if you have any of those fancy ones where you put it to the head, they're not reliable enough to use in children under 5. So we don't recommend those. So now we're going on to red flags. So very rarely temperatures can be a sign of severe infection. So it's really important as a pharmacist that you can look out for those and know to refer. So in the UK, if we want to refer from community pharmacy, we can refer either to the general practitioner, who is generally a family doctor, who is quite local to where you live, or we might refer to the emergency department. So I'll just go on to the next slide. So when you're talking about fever in children, you've always got to have sepsis in the back of your mind. It's probably, in the majority of cases, not sepsis, but it's always good to think sepsis. So for any child who is breathing very fast, has a seizure, convulsion, looks very mottled, very pale, very grey or bluish, has a rash that doesn't fade when you press on it, is very lethargic and difficult to wake. So on stimulation, they're very difficult to wake. It's very abnormally cold to touch, then you have to think about sepsis. And in the UK, we call 999 to get advice for a child like that. And for any child under 5 who is not feeding, who is vomited repeatedly and hasn't had a wee or a wet nap in the last 12 hours, they could also have sepsis if they also have a fever. So I think that's a really nice poster that you could have potentially in your shop to remind you of what to look out for. So in the UK, we have certain pathways for referrals. So we might refer to the GP for any child under 3 months who has a temperature over 38 degrees C. If they're 3 to 6 months, it's any child with a temperature over 39 degrees C. For an older child or any other child, it's a fever lasting more than 5 days. So that could be a sign of inflammation going on. So specifically with COVID, we've seen a syndrome called PIMS-TS or MISC, I think it's called in other countries as well, and also Kawasaki's disease. So anyone with a temperature that prolongs for more than 5 days, it's worth referring just to get them checked out. If they're less active than usual, normally, I know my kids, once I give them paracetamol, they're back up jumping around their normal selves. So if your child is really grumpy and not doing very much, then actually that could be a sign that they need to get a review. If they're getting worse despite all your best efforts to make them comfortable, and parental concern and distress. So like we said, so if there's anyone who has a concern for a child, then you need to listen to that concern. Sometimes parents are the ones who know their parents the best, their children the best. So you need to listen to those concerns. And if they are very concerned and you can't placate them, or you think they can't manage at home because of a social situation, then they should get referred to be reviewed. An emergency might be if the child is dehydrated, as Jack talked about. So a dry nappy, no tears, sunken eyes, dry lips, unusually sleepy, difficult to wake, and all the other symptoms that I went through on the previous slide. So for this one, I'm just going to go through some of the common bits of advice that might be given, and I want you to tell me which one is the right one, please. So baby records a temperature of 38.5 degrees C, which is about 101 degrees Fahrenheit in the pharmacy. The baby is grumpy but consolable. She's been feeding normally, had several wet nappies, and you are happy the baby can be managed at home. Which of the following bits of advice would you give to help manage the fever at home? So we can name them 1, 2, 3, and 4 to make things easier. So number 1, check on the child through the night. Number 2, that an antipyretic like paracetamol and ibuprofen should be given to lower the fever, even if the child is not distressed. Undress the child and sponge them down. And 4, give plenty of fluids. So if you just want to type in some numbers, and then I'll quickly go through the answer. Brilliant. So give plenty of fluids, definitely. Keep the child well hydrated. If they've got a sore throat, then kids love ice pops, anything cold like that. Give them a treat, give them some juice if they're old enough. Definitely number 1, check on the child through the night in case they get any worse. Number 2, you can give an antipyretic, but in the UK, we don't give an antipyretic unless the child is uncomfortable or distressed. If they're happily sat there with a fever, playing with their toys, you don't need to manage it. It's a normal response to an infection. You can just leave them to be happy. Number 3, undress the child and sponge them down. We don't recommend that anymore because that can actually make them have wriggles and make them really uncomfortable. So in the UK, we don't recommend that anymore. So if you are going to give a paracetamol or ibuprofen, which one of the following statements are true? Again, if you can put the numbers in, there's 1, 2, 3, 4, 5, 6. So medicine should be given if the child has a fever and is distressed and uncomfortable. We can give both paracetamol and ibuprofen together to reduce the fever. Ibuprofen is more effective than paracetamol. Parents should be advised how much to give via an oral syringe, including when doses are given. Aspirin may be given to children, and paracetamol is only available in one strength for children. So which ones of those are correct? If you just number them 1 through 6. Yep, perfect. So only give antipyretics if they've got a fever and they're distressed. Number 2, in the UK, we don't recommend that you give paracetamol and ibuprofen together. If you start with paracetamol and it doesn't work, you can switch to ibuprofen, but we don't recommend you give them together unless they've had a review by the GP or the hospital. Ibuprofen is just as effective as paracetamol as an antipyretic, but obviously if your child has asthma, you may want to prefer paracetamol first line. Definitely recommend how to give via an oral syringe, as Jack covered. Aspirin shouldn't generally be given to children for fever because of the risk of Raynaud's syndrome. And paracetamol is available in multiples of strengths and formulations. And this is where parents do make mistakes. So as a pharmacist, it's really key that you point out the dose, how to give it, and how to use the devices. So if it's the rectal suppository, how to give it, and a syringe, how to use that. I'm just wondering how I'm doing for time, Sarah. Do I need to hurry up?
No, you're fine, Jo, for a couple more minutes.
Okay. So mum has asked you now that she thinks her baby might need antibiotics to get better. What kind of advice are we going to give? Just a brief. Would you want the baby to have antibiotics in general, or what would be your advice? No. Good. I like that answer, Salome. So for the most patients, it's viruses that cause the fever for the majority. So only if you think that they're showing signs of a bacterial infection and then they need a referral to the GP. But for the majority of children, we don't give antibiotics because it doesn't help them get better unless they've got a confirmed bacterial focus for their illness. And it's actually better for babies, especially breast milk, you're right, to preserve their internal gut flora, which really helps keep their immune system and potentially helps them prevent allergies later on down the line. Should mum book a COVID PCR? So this is very topical in the UK at the moment. We're just going through another huge wave of Omicron is just about to hit us and has hit London actually this week. So any child reporting a fever or a new continuous cough in the UK would need to be booked in for a PCR test and would need to isolate as per the government's rule. So even though, depending on where you are in your current pandemic status, you may have COVID floating around, but yeah. Oh yeah, I like the point about the teeth, definitely. There's no proven cause that teeth cause fever, but they do definitely cause pain. So you can give painkillers for that if you need to. Safety netting, so as a pharmacist, it's really important that you give advice about how to stay safe. Mum asks what to do if the baby gets worse overnight. What advice do you give? Now, as a parent, I know that my kids always choose out of hours to get unwell. They never choose 9 to 5. They never choose Monday to Friday. It's always 10 o'clock on a Friday night or 7 o'clock on a Sunday evening when everything's closed and they get ill. So what advice are you going to give mum to access care out of hours, which might differ depending on what country you're from? So the advice I might give, so it's really important to tell them what to look out for. So it's important that they know what amber and red flags to look out for. and when to go to the emergency department and how they do that. You might need to think about what Jack said about the family situation. If mum's on her own and she's got 4 other kids at home, how's she going to manage that? Should she call an ambulance? Does she have an auntie or an uncle or a family member that can help look after the other children? It's not always straightforward to get to the emergency room, so it's worth thinking about the social situation and just having a chat about how realistically they're going to do that. In the UK, we have a telephone service called 111 that families can ring for advice about how to access out of hours care. So it's worth knowing in your particular country what the pathways are for parents. So I've just said here how to recognise red flags, ensure the family know how to escalate concerns and to access care if symptoms worsen. And again, sometimes in the UK, we do miss sepsis. So if a parent is really concerned, that it's important they feel empowered to communicate that and make sure that they are heard, that if their child is not getting better and they keep, especially during a busy winter, keep getting battered in and out of the GP, that they then know where to go and who to ask for help. So I've just noted here some really useful websites that we have here in the UK that cover fever in children. We have a nice guideline, and we also have information for parents in English. The bottom one, the 0 to 18 NHS UK, also has leaflets in other languages that you might find useful to give to parents. So check out the Wessex Parents Handout 0 to 18, because they also translate those leaflets into other languages. And a big shout out for Medicines for Children, which is also a UK-based site that provides practical and reliable advice about how to give medicines, and also unlicensed medicines that we use quite often. So pharmacists are really well placed, especially currently during winter. Well, we're in winter, you might be in summer. How to keep well. So what kind of medicines would you advise that parents keep at home? I think Jack might have covered some in his previous talk. Can you remember any of the medicines that you might want to advise families to keep at home to avoid having to go to the GP? Which again may vary from country to country. Yep, I like your comment there about antibiotics being ineffective during COVID. Yeah, there's very, very, very low percentage of co-infection with COVID of antibacterial. So definitely paracetamol, ibuprofen if they are not contraindicated to it. Rehydration fluids, definitely. Antiseptic creams, first aid box, antihistamines if required, if they're a particularly allergic child. And then my last point is about vaccination. So again, think about the health of the whole family. You're in a really key spot to remind families about the importance of vaccination. So which vaccinations can we recommend for the family over winter? Flu, for sure. So flu vaccine in the UK, we go down to 2 years, right up to adults. So the whole family generally can be vaccinated against flu. At the minute, everyone's having COVID. In the UK, we're not doing children at the moment. We're only going down to 12 years of age. But I know it's different for every country. But if you can have the COVID vaccine, then people should be recommended to have. I think we're on dose 3 now in the UK. Also, you might recommend pneumococcal for anyone with asthma. If you've got older family members, you might recommend the shingles vaccine. And then for any child under 5, you need to make sure that they're up to date with their routine vaccinations, whatever they might be within your country. So it's a really good opportunity just to chat to families about vaccinations and maybe dispel some of those myths that people hold about vaccination, because it is a real worry for families generally about vaccinating their children. And that comes to the end of my slide. I just want to say a really big thank you for everyone to taking part, because I couldn't have got through that unless you had chatted to me in the chat. So that made a really big difference. So thank you very much. Thanks, Sarah.
All right, thank you. Thank you, Jo. That was a really great presentation and very informative and interactive. It's actually summer here, not winter.
Yeah.
So we're on the opposite side of the world. But I've always loved the term safety netting that you use in the UK. And your slide that children never use Monday to Friday, 9 to 5 to be sick, and always choose after hours. I've learned that the hard way. So yeah, that definitely resonated. So we now might move to the Q&A. Thank you, Chris, and the panel discussion. So I have a couple of questions for you each, and some that have come through the Q&A function. I might just get you to all turn your cameras and microphones on, Heidi, if that's okay. So I might ask the first question to Jack. So firstly, Jack, what are some practical tips we can give to caregivers when it comes to managing medicines?
Yeah, sure. Thanks, Sarah. I think if you have multiple caregivers involved, written information is fantastic. So if they're dosing a child with the medicine, it might be great if they have even just a piece of paper next to the medicine with the time, the dose that was given, and even for which child as well, if they're juggling different children of different ages or twins even, there's all kinds of situations there. And I think that provides some kind of nice documentation and continuity of care between different parents or different caregivers. Any written information is certainly helpful. Alarms, apps, whatever's going to help those parents manage that. It's stressful to have your child be sick. They may also be feeling unwell themselves. I think those kinds of things, anything that just will make it easier and safer ultimately, if there's some kind of record and way for them to keep track. There's a whole bunch of different guidelines on helping children take medicines as well. So might be able to find something. I know in Australia, we have a couple of fact sheets about teaching kids to swallow tablets, for example, when they're transitioning to there, or even just looking up whether certain medicines can be mixed into food or with a different drink, for example, if the parents are having trouble getting kids to take the medicine. Yeah,
absolutely. Thanks, Jack. Joe, I might come to you now. And the question is, pharmacists have such an important role in assessing and referring. And what should pharmacists do if they are unsure of what to do?
I guess the safest thing to do is, if you're unsure, is to refer, because it's that for a child, it's quite often difficult as a healthcare professional who is not trained to clinically assess signs of illness. So you're going off symptoms. And quite often, as Jack quite rightly said, either families or children cannot communicate those symptoms effectively always. So if you're not sure, I would say it's always better to either ask a colleague, if you have a colleague, what they would do in the same situation, or to refer them to a doctor for review, because it's the safest thing to do. So if you're not sure, you can always take the chance to check your local guidelines and then to do some self-learning. But if you have any doubt in your mind, I don't know any paediatricians that would mind a referral because you weren't sure, and there was something in the back of your mind that thought, actually, this doesn't make me feel quite safe. I'd rather refer for review. So, and I haven't met one. I know A&E are very busy, so the emergency departments, but I don't think they would ever, get cross at anyone who is unsure. So it's always safer to refer if you can't get the answer from within yourself or a colleague, would be my advice, because you are going off symptoms. So unless you're trained as a clinical advanced practitioner to take respiratory rates, temperatures, to do a full proper assessment, you are as a community pharmacist always going off what you are told and symptoms. So you have to be quite a good historian to get the full story. But if you do start to think, this is feeling a little bit on the edge of I'm not sure or amber, then yeah, I would always refer.
Absolutely, that's very good advice, Jo, and I would do the same in my practice as well. Heidi, I might move to you. So one question that I had was, what should pharmacists do in the case of unavailability of pediatric dose of certain medications?
Okay, thank you. Actually, this is a real life problems and real life scenarios. What we actually do is to refer to adult formulations present in the pharmacy and try to formulate a pediatric one from it. I can give a real life example that happened, I think, 2 days ago with me. I had a small child present to the pharmacy with severe symptoms of influenza. So his pediatrician need to prescribe the oseltamivir for him. And here in Lebanon, we don't have the pediatric formulation or even the powder form to be reconstituted. So what we actually did in this case is to bring the adult dosage, the 75 milligram, and formulate it. We dissolve this capsule, the powder in the capsule, and give a pediatric dose of, I think, 6 milligram per milli. So the answer is, if we have alternative adult formulations, we can bring pediatric dosage from it. The real problem is that when it's totally unavailable, both the pediatric and the adult formulation, here we need to go to certain alternatives.
Absolutely, absolutely. Thank you, Heidi. All right, I might come back to Jack. Now, my second question for Jack is one that's come through the chat box. So firstly, Jack, which analgesic is recommended under 1 month of age for children in Australia? And should you give cold preparations, for example, dihydramine to babies under 1 month?
The simple answer to that is, in Selfcare, if you have an infant presenting in the pharmacy under 1 month of age that's unwell, it's probably best that they're reviewed by a doctor sort of as soon as possible. So ideally, as a pharmacist, you're not going to give them anything. Not a neonatal pharmacist, but to the best of my knowledge, you can use paracetamol in infants under 1 month of age under close medical supervision where that's appropriate. But if we keep the focus on self-care and our scope of practice in community, I would tend to be avoiding supplying any medicines to infants that young. And cold products, I would really be querying the need for those products in an infant that young as well. So thinking back to me banging on about whether there's a need for the medicines, I think, yeah, just reflecting on that. So the short answer is we wouldn't be handing out any of those to a young infant.
Thanks, Jack. Absolutely. All right, Joe, you're up next. So one through the chat box was just asking around the useful resources for your practice, and I wondered if you had or could provide any advice to the audience as to the resources that you use in your day-to-day practice around self-care advice or pediatric doses for medicines in this area.
Yep. So in terms of advice, we have NICE, who are the National Institute for Clinical Excellence, who evidence-base all the advice that we give. So we have a guideline for fever under 5. We have a guideline for sepsis in children. We have a guideline for UTI. We pretty much have a guideline for every childhood common condition. So if you Google NICE and then whatever you want to look at, that will come up and there'll be evidence-based guidelines. NHS.uk is a really good website that has advice both for professionals and for parents. So if you want to give out a leaflet about how to manage fever at home, then the NHS websites have really useful information. NICE also have these traffic light boxes. So they will traffic light the symptoms for you to review. So green can be managed at home, amber needs a primary care GP doctor review, and then red is emergency, needs to see an emergency hospital doctor really quickly. So those are really helpful to help you triage where the patient should go and whether they're okay to self-manage at home. And then medicines, in terms of medicines information, in the UK, we have the BNFC, so the British National Formulary for Children, which has doses in there specifically written for children, including unlicensed. In Southeast London, we have the paediatric formulary from Evelina Children's Hospital that we share with King's and the Brompton. And that, again, it's probably more aimed at hospital pharmacists rather than primary care. So the BNFC is more likely to be useful to you. And then Medicines for Children is brilliant. It's got loads of leaflets and videos on how to use syringes, eardrops, suppositories, but also has leaflets on unlicensed medicines. So if you come across a child with a complex condition on various medications, you could have a leaflet. Because the problem is in the UK, a lot of the medicines that we use don't have a license. So, for example, if you needed to give aspirin for a child with a cardiac condition, then the leaflet would say all over it, don't give it to children. But actually that child has been assessed by a specialist, they need to have medication. So there's a leaflet on there to explain how to use it safely for that particular condition. So Medicines for Children is a really good website that's been written specifically for families and includes really useful advice about like what happens if my child vomits this dose, what happens if I forget, what happens if I give too much. So it's really, really practical advice.
Absolutely. Thank you, Joe. That's really informative. All right. Lastly, I might move to Heidi before I pose a question to all. Heidi, the last question is one through the chat box, and it's, can you discuss a little bit on compounding pharmacy for pediatric formulations?
Thank you for this important question. Actually, this is one of the main problems that we are facing, especially in our country. And this opens a window or link to an extemporaneous pediatric formulation that is not being trendy nowadays, not only in less developed countries, but also in some countries because of unavailability of these pediatric formulations. Actually, we do at a small scale in our community pharmacy, we do some formulations, but this depends on the availability of the raw materials and on other availability of some excipients. At a small scale, this could be managed a little bit in a country like Lebanon, but actually it still remains a big problem because of many reasons. As I said, here we don't have too much raw materials. We don't have any excipients. It's very, very rare to have some excipients. We don't have any references or protocols for the right compounding or right formulation of this. It's only a personal effort to do and to learn about these. The Ministry of Health or even the syndicates of pharmacists or even the physicians, they don't have such guidelines. So actually it's a big problem, yeah. But for certain medications, especially, for example, some topical ones, it's easily because we can combine certain creams, ointment, for certain suspensions that, as I said in the previous example, we can dissolve with a certain ingredients. It's okay, but for more sophisticated problems, it still remain a big issue here.
Absolutely. Thank you, Heidi. That was a great answer. Now, I might ask one last question for all of you, and we've got 2 minutes left for the panel discussion. So my question is, self-care is such an important area, and pharmacists provide self-care advice every day in practice, whether it's in community pharmacy, hospital pharmacy, or wherever they're practicing, particularly for new mums and breastfeeding mums who may be unsure of or unaware of what to do and when to seek advice and self-care that they can provide to bubs and mums. So my question is, what do you foresee the role of the pharmacist in this area moving forward? So I might start with perhaps Heidi first.
Okay, actually, this is our everyday practice, and every day we are bombarded with many questions, especially nowadays with the availability of the social media, WhatsApp, Facebook, Insta, and even messages. So it's being a lot of questions, especially by new moms, by some anxious moms, for example, or sometimes for certain moms that have a certain special case. Give an example. I am here in a live session. I have been receiving many questions on my phone from different moms. What we actually do is that we try to give many statements, many printouts, if these are available for them. We give them some resources to refer to. Sometimes we inform him about some red flag symptoms that they need to call the physician or pediatrician directly instead of calling the pharmacy and then referring. Sometimes we make a small gatherings as education gatherings for some important diseases, starting from breastfeeding, medications, some important symptoms to notice in children. we do these gatherings either in the pharmacy if the space is okay, or sometimes we go to certain public areas or certain health centers and doing audiovisual activities, or even nowadays we can do live seminars to a less extent.
Thank you, Hayley. I might move to Joe now. Thanks, Joe.
Sorry, I missed the question, sorry.
So the question is, what do you foresee the future role of pharmacists in this area?
I think it'll be growing massively. And I think, I know certainly in the UK, the direction of travel is that when anyone finishes pharmacy school, that you'll also be a prescriber. So your level of assessment, clinical assessment, will be a lot higher within community and within hospitals. So we will be much more able to not only manage self-care, but also prescribe relevant treatments to manage those at home. So I think as we go forward, we'll be able to use our skills better, but also enhance our skills to be more clinical. And I also think the links will hopefully be less divided between doctors, pharmacists and nurses, so that we'll be seen as part of the team, not just the person in a shop. So that you will be an additional member of the clinical team who can provide a clinical review. So certainly in the UK, that is where we are hoping to head in the future. And that the care is a lot more joined up and that everyone talks more to each other. So that if you do have a child with complex needs, that the information and the plan of care is much better communicated all the way through from hospital through to community pharmacists, so that care is integrated around the family rather than the family having to struggle between so many different healthcare providers.
Yeah, absolutely, Joe. Thank you. And lastly, Jack, I might call on your response.
Yeah, sure. I mean, I think times are definitely changing in pharmacy. A lot of our role could arguably be automated. So as we move away from that sort of traditional dispensing role, I think it's important that we do step out from behind the dispensary counter and really engage with people and think about what can we offer as pharmacists that Dr. Google can't, or that information sheet online can't, which is really that human interaction, providing reassurance, answering those questions, and really giving individualized attention to those people and providing advice that's tailored to them, and certainly expanding our role. For more holistic care, we can provide vaccinations, if we can start prescribing, as Joe said. Thinking about how we can grow as a profession to really drive that area if we're starting to move away from what would be traditionally seen as pharmacist roles.
And I think within that, you're also thinking about developing your other staff, so your pharmacy technicians, and empowering them to take on some of the more traditional pharmacist roles. So yeah, I think that's a really big part that can play to allow us to step out from behind, you know, the dispensing shelf or the compounding, that you need the support staff to enable you to do that.
Absolutely. Absolutely. And I totally agree, Joe. All right. Now I'm just aware of time. We've got 2 minutes to go, so I might wrap up and conclude everything. So colleagues, the importance and relevance of self-care and self-medication in health policies and healthcare systems is critical, as the evidence indicates that individual and population involvement results in significant improved clinical, economic, and humanistic outcomes. Many countries have embedded the concept of self-care in their health policies, such as Joe's mentioned in the UK, with the objectives of increasing patient engagement, directing patients to the appropriate level of entry into the healthcare system, and optimizing healthcare resources. For sustainable improvement, self-care needs to be addressed in a systematic way and requires combined action from individuals, healthcare providers, and healthcare systems. So I'd lastly like to thank all our panelists, Hayley, Jack, and Joe, for giving their time to present in this webinar. The next webinar, Innovation in Self-Care Models Shaping the Future Together, will take place in the new year, which is on the 13th of January between 11 and 12:30 CET. And so please make sure to register by scanning the QR code as seen on the slide. The recording of this episode will be made available on www.fip.org, and please give your feedback to webinars@fip.org so we may continue to improve our digital events offering in the future. Again, I'd like to sincerely thank Reckitt for supporting this online program. Thank you so much. Before we close, I'd like to draw your attention to the recent publication, Cold, Flu and Sinusitis, Managing Symptoms and Supporting Self-Care, a handbook for pharmacists. The handbook describes the role of community pharmacists in the management of upper respiratory tract infections and includes specific guidance for the common cold, influenza and sinusitis. I would like to encourage you all to access it using the QR code on the slide. And we might not have time for the video, but again, I'd just like to thank you very much for attending. Safe holidays and good day to you all. Thank you very much, and see you soon.